Good afternoon. It's my pleasure to be here for the second time. In the previous lectures, we discussed about the abnormalities of the rate and rhythm, and we completed. And for this session, we discuss about the abnormalities of the QRS, ST, T wave, and QT interval. And in order to understand the ECG interpretation, there are few basics in the ECG you have to know. Whenever there is a signal, it passes toward the lead, this lead will become positive, and the opposite lead will become negative. The second rule of the ECG, usually lead 1 AVL represent the left side of the heart, while V1 AVR represent the right side of the heart. The inferior wall represented by 2-3 AVF. So if you have a signal arising from the right side toward the left side, we expect that lead 1 AVL will become positive and V1 AVR become negative. And in contrast, if it is from left to right, the AVR and V1 become positive and AVL become negative. And any signal from the inferior wall toward upwards, the inferior leads become negative. In horizontal plane, this is the base of the heart, this is the apex of the heart. And usually if you put an ECG leads, this is V1, V2 expected to represent the base of the heart, while V5, V6 represent the apex of the heart, and V3, V4 is in between. The normal axis of the heart is usually between -30 and +90. And the simplest way to identify the axis of the heart is to look lead 1 IVF. If both of them is positive, usually it means there is normal axis. As in this example, lead 1 IVF is usually positive. In left axis deviation, we expect that the lead 1 positive, IVF negative. Because the IVF, as I told you, is located in this area, inferior, so the direction of electricity is opposite to the IVF. So IVF is expected to be negative. In right axis deviation is opposite. The direction of electricity is toward the IVF, while it is away from lead 1. So the lead 1 is negative, IVF positive. And we have extreme axis. Usually this occurs in patients with VT, when all leads become negative, only IVR. To understand the concept of the axis deviation, this is a transesophageal echo. This is left atrium, this is left ventricle. Suppose there is a focus of the VT arising here, we expect that the direction of depolarization is away from this signal. If we put an ECG lead, lead 1 is opposite to this direction, IVF also opposite, so both of them become negative and the IVR become positive. And of course, each one of them has several causes. I will not enumerate the causes because of the sake of time. You can read later on. We have pathological Q wave. What is the definition of pathological Q wave? Usually, pathological Q wave occurs when there is scar or advanced cardiomyopathy. Let me share this patient with you, 65 years old diabetic man presented with acute onset crushing substernal chest pain. And this is the ECG of the patient. You can appreciate there is a deep Q wave in the inferior lead and there is ST segment elevation. So this is the pathological Q wave. What is the definition of pathological Q wave? It should be more than 40 millisecond wide and more than 2 millimeter deep, as in here, or simply if it is more than 25% of the QRS length. Another abnormality of the QRS is evidence of left or right ventricular hypertrophy. Usually it is a common finding. The causes could be due to aortic stenosis, could be due to hypertension, hypertrophic cardiomyopathy. Whenever there is a pressure overload inside the left ventricle, we expect that there is some left ventricular hypertrophy. And usually we have several criteria for definition of left ventricular hypertrophy. We have the simplest one is Sokolov-Lyon criteria, the summation of the S in V1 and R in V5 viscous more than 35 millimeter or more than 7 large square. The voltage criteria of the left ventricular hypertrophy should be combined with non-voltage criteria in order to say that the patient has left ventricular hypertrophy. The non-voltage criteria is the repolarization abnormality. I mean, there is STT changes. Right ventricular hypertrophy is the same, but the changes mainly in the V1, V2. As I told you that V1, V2 represent the right side of the heart. And of course, we have several causes for each of them. And this is a very important. We have bundle branch block, we have left bundle, we have right bundle, we have intraventricular conduction delay. In general, whenever you have left bundle branch block, as in this figure, the depolarization has to complete the right side and then shift it to the left in this direction. That's why the time delay represents the widening of the QRS complex. And as the direction of electricity is toward the viscous is expected to be positive and V1 become negative. So the criteria, there should be more than 120 millisecond and dominant S in V1, and there should be dominant R in viscous, and absence of any septal Q wave. This is the classical ECG finding of the left bundle branch block. This is widening of the QRS, and there is deep S in V1, and there is positive R in V5 viscous. And we have right bundle branch block, the same, but the difference is just in the V leads. When you have a block in the right bundle, the direction of electricity completed the left side, then it has to go to the right side, and the ECG criteria expected to be positive R in V1 because it is toward the V1, and also deep S in V5 viscous. Regarding the causes, we have several causes. The most important is pulmonary embolism. You have to put in your mind. This is a 62-year-old man presented with acute onset shortness of breath 2 weeks after prosthetic surgery. And this is the ECG finding. Usually in this scenario, patient with chest pain and after surgery, the first thing comes in your mind that pulmonary embolism. But of course, we have several causes we have to deal with, because also acute coronary syndrome sometimes can occur after surgery, as the surgery is in hypercoagulable state. Frequently, you may see myocardial infarction after surgery. But of course, in this patient, the first differential diagnosis in my mind is pulmonary embolism. As we expected, this is the echo finding of the patient. There is hugely dilated right side, and there is D-shaped septum, which is a features of pulmonary embolism. Usually, the changes of the ECG in pulmonary embolism is due to mechanical pressure of the conduction system. That's why it becomes incomplete or complete right bundle branch block. This is another example of right bundle branch block. There is positive R in V1 and deep S in V5, V6. And usually in the textbook, we use it to know that the pulmonary embolism causes S1, Q3, T3. But this is not sensitive nor specific, because frequently you may see such a pattern in a variety of conditions. The most ECG abnormality in pulmonary embolism is sinus tachycardia, actually. And you have to know that 18% of patients with pulmonary embolism usually have normal ECG. So ECG doesn't exclude the pulmonary embolism. This is another patient with right bundle branch block. but patient has history of acute MI before 1 week. So right bundle branch could be due to ischemia, could be due to pulmonary embolism, could be due to congenital heart disease, and so on. This is intraventricular conduction delay. As I told you that for the left bundle branch block, there should be positive RNV5 viscous. This ECG, from the first look, you can identify that this is left bundle branch block. But close observation, when there is negative QRS in V5 viscous, it means there is non-left bundle branch, and the diagnosis is intraventricular conduction delay. And of course, we have to look for the voltage of the QRS, the definition of low voltage, when it is less than 5 millimeter in the limb leads and less than 10 millimeter in the precordial leads. And as a common sense, whenever you have a low voltage, there should be some barrier between the heart and the electrode of the ECG. This barrier, due to fluid, could be fat, could be air, or anything. This ECG was taken from a patient with mass pericardial effusion, and as you know, there is low voltage, as there is large amount of the fluid between the heart and the ECG electrode. And look for evidence of any delta wave. This is the ECG taken from the 38 years old with intermittent palpitation. If you look to this ECG, there is a slurred upstroke of the QRS. This is what we call delta wave. If we magnify this area, this is a delta wave. Why this happened? Because normally the depolarization occurred through the IV node His-Purkinje system. But in accessory pathway or in pre-excitation, there is a competition between the IV node and the accessory pathway. So the first deflection usually transmits through the accessory pathway, produce this slurred upstroke, and the last portion of the ECG is due to IV node His-Purkinje system. Okay, another important part of the ECG is to assess the ST segment, T wave, and QT interval. We have several causes of ST elevation. Not every ST elevation is due to myocardial infarction, but every ST elevation should take seriously. This ECG was taken from a 25 years old with no risk factor, presented with chest pain. If you look to this ECG, there is ST elevation, but it is diffuse ST elevation involving both inferior and anterior leads, which is unusual for myocardial infarction. Usually in myocardial infarction, the ST elevation is localized and associated with reciprocal changes. But in pericarditis, this is a classical ECG finding of acute pericarditis. There is no localization and there is no reciprocal changes. And one important thing, there is PR segment elevation in IVR. This is ECG from another patient with acute myocardial infarction. This is a ST elevation in the inferior lead. And also there is another finding. There is ST depression in V2, V3. This ST depression usually regards some involvement of the posterior wall. Because in posterior myocardial infarction, we cannot catch the ST elevation, as in this picture. But if you upside down the ECG, this ST depression will become ST elevation, and this R wave become Q wave. If you put an ECG lead posteriorly, you can catch this finding in patients with posterior myocardial infarction. This is another patient, 50 years old, with history of ischemic heart disease, but with atypical chest pain. Also, there is ST segment elevation, and there is deep Q wave. When we do echocardiography, there is a big apical aneurysm. So this ST elevation remains forever. This is due to apical aneurysm. So not every ST segment elevation regarded as a new one until proven otherwise. But every ST segment elevation should take seriously. That's why the history is very important. ECG features of aneurysm, when the ST elevation remain more than 2 weeks after myocardial infarction, we consider it as aneurysm, and most commonly seen in the precordial lead, and usually associated with deep Q wave. And there is no reciprocal ECG changes, because in acute myocardial infarction, there is some reciprocal ST depression in opposite leads. But here, there is no reciprocal changes. And this is another patient, 40 years old, attacks of dizziness and syncopal attack. It is classical ECG finding of Brugada syndrome. ST elevation is just in V1, V2, and it is coved-shaped. So this is a Brugada. And this is another ECG which is very interesting for me. 14 years old male patient with mixed aortic valve and VSD, diagnosed with infective endocarditis, presented with severe chest pain. So this ECG, usually it is left bundle branch block. It is very clear, wide, and there is deep S in V1 and positive R in V5 viscous. And the baseline ECG of the patient also left bundle branch. So it's sometimes very difficult to interpret ECG for patient with left bundle branch block. But we have a criteria we called Scarboza criteria. This criteria help us to diagnose acute insult in the setting of left bundle branch block. If you have a concordant lead, I mean positive leads with ST segment elevation more than 1 millimeter, is significant. And if you have ST depression in V1, V2, V3, it is also important. And any ST elevation more than 5 millimeter is also important in patient with left bundle branch. And nowadays we have modified Scarboza criteria, ST elevation more than 25% of the previous S. If you have this S, this ST elevation more than 25% of the S wave is also important, regarded as a new insult. If we come back to our patient, you can appreciate there is more than 5 millimeter ST segment elevation in the discordant lead, and also there is ST elevation in the concordant lead, more than 1. And unfortunately, the patient suffered from acute myocardial infarction secondary to vegetation in the aortic valve. This is another patient, 25 years old, presented with atypical chest pain. This is also very common ECG finding. This is also ST elevation. What we call this ECG is benign early repolarization or high takeoff phenomena. Also, it's called smile face ECG or fishhook appearance, when the ST elevation occurs just in the J point and there is a notch in the J point. I finished the ST elevation. Now the ST depression. The ST depression is also very common ECG finding. We have several causes for ST depression. The most important is myocardial ischemia or infarction, or sometimes due to tachycardia, maybe due to left or right bundle branch, or RVH, LVH due to repolarization abnormalities. Sometimes in drugs like digoxin, which cause reverse tick sign ST depression, or electrolyte disturbance. So as I told you, that history very important for any ST depression. This patient has diabetic and smoker presented with this ECG. So it is very simple. This ST depression is most likely due to acute coronary syndrome. But without history, there is a large list of causes. We cannot catch the causes exactly. This is again some ST depression, but not due to myocardial infarction. This is in patient with tachycardia, AVNRT. This is a left bundle branch. This is left ventricular hypertrophy, and this is pre-excitation, WPW syndrome. All of them associated with ST depression. T-wave. The T-wave, regarding the causes, exactly similar cause to ST depression. Again, This is a 60 years old man, smoker, presented with this ECG. There is very clear deep T inversion in V1, V2, V3, V5. So this is due to acute coronary syndrome. And this ECG taken from a patient with large ischemic stroke. So this is due to raised intracranial pressure. And this ECG was taken from a patient from hypertrophic cardiomyopathy. This is also deep T inversion. So not all T inversion is due to MI. We have different causes. And we have Pickett T wave. The most important causes of Pickett T wave, we have two common causes: myocardial infarction, which we call hyperacute T wave, or hyperkalemia. These two causes are very common. And the last portion of the ECG is the QT interval. QT interval, normal QT is less than 440 milliseconds in men and less than 460 milliseconds in women. And of course, we have different causes of prolongation of the QT, especially electrolyte disturbance, also raised intracranial pressure, myocardial ischemia, drugs, and congenital causes. This patient has history of thyroidectomy 10 years ago. And this ECG. You can appreciate there is very long QT. As a rule of thumb, whenever the QT interval is more than half of RR interval is regarded as prolonged QT, even without correction. This is another patient with long QT, but it is due to raised intracranial pressure. The patient has subarachnoid hemorrhage. And frequently, the long QT may develop polymorphic VT, which we call torsadipua VT. Thank you.